John, I think you perhaps have
John, I think
platform open.
John, I think platform open. John.
Right then, ladies and gentlemen, thank you for joining us on the second session for the resuscitation competition. We've had a very successful paediatric session some moments ago, and I'm very excited to bring to you the second session focusing on NLS. We have been running these competitions for a decade now, and this year would have been the first live demonstration of neonatal life support in Manchester. Sadly, because of everything that's been going on recently, we've had to transfer everything across to online, and we've made some adaptations. We've received some videos of the perfect neonatal life support resuscitation, and it gives me great pleasure to introduce my co-chair, who will just outline the competition and how these sessions are going to work. So it gives me great pleasure to hand over to Lucas Fansel-Lisacek.
Thank you, Robin, for the introduction. And I'm also very excited for this very first neonatal session. And we've had a good discussion in the pediatric one right beforehand. And it's always a challenge, of course, to move this thing towards virtual. So how does it work? We've called for videos from all countries, basically. So the National Resuscitation Councils approved them, then they were sent to ERC. We had our experts from the Science and Education Committee reviewing them. So that was the first step. Eventually, now we're gonna take a closer look at the videos while discussing certain scenes. And after that, the experts from the SAC, together with the national councils, will each perform a rating of the videos. Those ratings will be pulled together, and then we will see who the winner of this prestigious competition is. And besides all that, we also have an interactive session right here, because you can, of course, raise questions. And we will have a poll where you from the audience can, of course, also rate the videos and elect the best one as you assess it. And that's the way the competition works. And back to Robin right now.
Thank you, Lucas. Without further ado, it gives me great pleasure to introduce two esteemed colleagues from the ERC, John Madar, who is chair of the education chair for the NLS SEC, and Charles Ruhr, who's the scientific chair for the NLS SEC, who will take us through the submitted videos and lead us, I hope, in a very interesting discussion. Thank you very much, gentlemen.
Okay, thanks for that, Robin. So this is a novel experience. I'm going to admit that this is the first time I've tried anything in this sort of format. So I'm going to apologize in advance if some of it seems a little unrehearsed, but there's a reason for that, and it's because it's unrehearsed. So we'll just have to see how it goes. So we've got a situation where we've sent a simulation script out to various parties in Europe, and one or two had the courage to actually grasp the nettle and come back with some structured videos of a simulation based around the story they were told. So we're going to look at those simulations, as Robin said, you know, all credit to the guys who've put these together, because it takes a lot of effort to do that, and then it takes a lot of courage to send it in for everybody else to look at your performance, recognizing that people will naturally criticize elements of that. But hopefully we're not here to criticize today, we're here to learn. From where I'm sitting, I'm thinking of this in two levels. One is, yes, we'll look at the clinical practice that's demonstrated during the simulation, which will be of interest, and there may be some compare and contrast as to how different people have approached it. But the other one is to step outside the simulation and look at it not as a clinical delivery of care to an infant, but how is it running as a simulation? What can we learn about simulation? Are there some tricks of the trade that we can discuss that will help us all in delivering this sort of teaching to others? So if we can look at it at both levels, I think it might be quite a productive thing to do. We were blessed with 2 simulations, which makes job a little easier. We didn't have to wade through 5 or 10. We had 2. We had one from Turkey and we had another one from Austria. In the pediatric session, I think Austria were the ones who started, so we decided to reverse it. So we're going to look at the Turkish video first. And the video play is being done remotely, so there's a little bit of dialogue in order for us to navigate through the video, but hopefully you'll pick it up. So if we just start with the Turkish video.
Hello, Turkish team.
Hello.
Hi. I'll give you one scenario so that I need a team leader. Who wants to be?
I can be. I want to
Okay.
get a team leader.
Can you learn the team leader name, please?
My name is Yeşim.
Yes. We have, you're called for a baby.
Yes.
It's a phone delivery baby. And 41 gestational age, 41 week gestational age. First of all, it's not suspecting any problem indeed, but after delivery, you're called for help. You have your team and you are coming with an ambulance. I'll give you a few minutes to look and check for your equipment, and maybe you can just discuss for the role, place, okay? And then after you said that you're okay, your time will be begin. Is everything clear, Yeşim?
Okay, as I understand, this is 41 weeks of gestation.
Yes, term
There is
baby.
a term baby delivery at home.
Yes.
And because of the baby situation, we are on call and we are going to that home by an ambulance
Yes.
with my team.
With your team and
And
with
with
your
you.
equipment.
Okay, thank you.
And you have a few minutes to talk it together.
Thank you.
Thank you.
Hello team, how are you?
Thank you.
We are in emergency case. We are in the ambulance. We are going to a home, which is the delivery, baby delivery has occurred. It's a 41 weeks of gestation. Only one baby, but they have no other problem in the mom. But because of baby now situation, we are fine. Okay. Also, whenever we get that home, you have to check the environment. Be prepared for the baby and the mother.
Okay, I'll check them.
And for equipment, extra, be prepared for that 41 weeks of gestation baby with your drugs, all those suitable equipment for ventilation, for airway, and other things. And as for babies, water signs and monitorization. This is your job.
Okay,
Is
I
clear?
will check the proper preparation and
Equipment
equipment
and
and
the-
drugs
Drugs and,
and EKG, pulse oximeter and other monitorization.
if you need an IV line, you have to put the umbilical catheter and do the drugs.
Okay.
Thank you. Tolga,
Okay.
whenever we get that home, you go to get the baby,
I will
and
get
make
the
your
baby, okay.
assessments, initial assessments,
Okay.
and then for the airway, for the ventilation, that is your job. Is
Okay.
it clear?
Yes, I will make the initial assessment and then I will manage the airway and the breathing.
Okay. As I know that you're all certificated trainee persons, this are our fault. Thank you.
Okay, thank you.
Thank you.
Are you okay?
Yes,
Is everything clear?
Yeah,
Yes.
yeah,
Okay.
good.
Let's go with an ambulance for the baby's house then.
Okay.
Okay.
Okay, so there. So I thought that was quite an interesting opening session, and one of the things I just wanted to point out is the fact that they're all dressed in PPE, and it just reminds us that both in simulation and in the real life we're having to cope with the burden, I guess, of PPE. And for me, it's something which is an impediment in some ways to the teaching, because it's actually quite restrictive when you're working. So these poor guys are dressed in a full gown, gloves, goggles, masks, so they're taking it seriously. They've actually dressed up in full PPE, which is something I think we all have to think about. What do you think, Charles?
Yeah, no, I agree with you. It's a matter of looking at your local situation. If you have a high caseload of COVID-19 patients and pregnant patients, that may be the approach to take. Whereas if your regional caseload is less daunting, then maybe you would go to level 1 PPE. Great credit for doing a scenario in full level 2 PPE. That must be very, very steaming hot in there.
I think it's obviously not a simulation center, or if it is, it's a well decorated one, but just illustrates again how pragmatic we need to be. What I did like, particularly with that briefing, was the bit at the end where the team leader is very clearly delegating tasks and roles to each individual. So obviously a luxury of time to do it, but I think both in simulation and in real life, there is value to people being very clear on the tasks they're expected to do. And I thought that was very clear. And not only did she give it to them, she then asked them to clarify it back, which I thought was good practice. So, you know, that's something we don't always do, but I think for this simulation, that was an element of good practice. I don't know whether Robin or Lucas, you have any comment on that?
I was interested in particular in that part, in the detail that they went into in that role allocation and the length of time spent on it, and I think perhaps given that the fact this is a predetermined scenario and a teaching scenario, they were willing to take that time and labour the point a little bit. But I wonder about the reality of it in transferring these skills to a clinical environment, whether you'd have that much time to carry out that task, and whether perhaps a rapid and slightly more brief approach might be required in the clinical environment.
So I take your point. I think when it's an emergency, I would totally agree with you, because you don't have that time. Actually, for the planned preterm deliveries, that's exactly what you do have, is enough time to do that. This was a meconium delivery of a baby, and the baby is either out or imminent. So I think for that particular situation, your point is valid. Should we let it play?
Okay. Hello. Aysun, check the environment. Make sure that it's warm.
It's okay. I'm closing the window.
Mother, wheelchair, I'm taking your baby. We will take care of him for a while, okay? Don't worry, please. I'm getting away the baby 2 meters away from the mother.
Oxygen is here.
I'm drying the baby now, but the baby is unresponsive now.
How is baby? Is it breathing, crying?
There's no sign of breathing or no sign of crying now.
What about the tonicity?
Well, the baby is
Fluffy baby.
fluffy.
Baby.
So no waiting, no crying, fluffy baby. So we dry the baby, we keep
Towels are
him
removed safely.
warm, and be sure that is any secretion, because this is a fluffy baby.
I would like to clean the secretions now.
Is there
First
any
the
other
mouth.
problem?
I clean the secretions here.
There's
And
amniotic
then the
fluid,
noses.
particular amniotic fluid on there.
I will enter
Looks
I
blue.
clean the secretions
baby.
in the
This is meconium covered, amniotic fluid covered baby. So we are starting immediately. Oxygen, positive position ventilation, positive pressure ventilation.
Okay.
Is there any trouble, baby?
Low 60.
Okay.
Yeah, it's 40, heart rate is 40.
I'm ready for ventilation.
Okay. Start before ventilation.
Okay.
20.
So Charles, do you want to talk about this bit?
Yeah, no, thanks, Jonathan. And I really enjoyed watching this video the other night after it was submitted, and credit to the team. You said it before, this is not a simulation lab, but it is clear that we're currently seeing a baby which is under no form of active heating. So this is a baby which has been dried and put on a surface, but it's not on under a radiant heater or some external heat source. So that always exposes the baby, and that gives rise to a rapid fall in body temperature. Just wanted to point it out, fully appreciating that this is not filmed in a resuscitation lab.
So I guess if we were doing this, we might expect some recognition of thermal care through wrapping of the baby?
If it was a preterm baby, we would certainly do this. This looks like a mannequin for a term-born infant, so certainly the guidelines wouldn't advise wrapping. But what the guidelines very clearly state is to avoid any element that increases heat loss, and that includes convective heat and conductive heat loss, draft, and exposure of a wet baby. So all of this needs to be taken care of. And credit to the team, I can see the towel is wrapped around the head like a little hat, and it was very clearly stated that the person who now holds the self-inflating bag was actively drying the baby, which is really a good thing.
Yeah, and I noticed that there was quite a lot of chat from everybody in the team all at the same time. So for me, I was actually struggling to work out exactly what everybody was doing at certain points in that sequence. One thing I did notice was there's the little sucker device here, this bulb suction device, which I guess is something you might see in the community, but we wouldn't see in hospital. We'd expect something more electric or vacuum orientated for the purposes of suction. And I was thinking that they were very straight in with the suction, perhaps, compared to what we might expect, because if we followed NLS specifically, we would inspect under direct vision and then suck out if the baby was floppy on the current guidelines. And I thought perhaps because they were already primed to the simulation, maybe they were just going straight in because they already knew.
I agree with you, John. And there was mention of an unresponsive baby, so I can see that they were worried. But yes, I would expect some direct vision and inspection of the larynx.
So, and I guess the other observation that I've got here is I'm looking at the bag and the tools that they've got, and for the purposes of providing respiratory support to our babies, we recommend a 500 ml bag. And I guess, again, it's pragmatic and it depends what equipment you've got available to you. But to my mind, that looks like a 250 ml bag or something like that.
I agree with you. It does look like a 250, maybe 300 ml bag. It also looks like there's a filter, which may be in accordance to the ILCO resuscitation update, to use an airway filter when possible when dealing with potential COVID. So well done, team. I'm quite impressed to see that. And I'm also quite impressed that the baby already's got ECG electrodes on, and I can see the SATS monitor. So within very, very short amount of time, this baby's been completely hooked up to monitoring, which is impressive.
So let's let it play.
21%
of oxygen. First
oxygen.
I start in room air with 2 hands, face mask ventilation.
Breathe 2, 3. Breathe 2, 3.
Okay.
Breathe
Is it
2,
okay?
3. We are not okay. Chest is not moving.
I'm not comfortable with the chest not rising.
Please check the
now.
mask, head and neck position.
Okay,
And
I'm checking again
sure
the
about
head and
separation.
neck position. And
Remember, this is
I
important.
increase the pressure now. Okay, we try again.
Yes,
It's better
yeah,
now.
It's better,
Chest
yeah.
is
We have,
moving. Breathe
now
2,
we are
3.
seeing
Some
chest
movement, I think there is
Okay.
normal.
2, 3.
Okay.
Breathe
We
2,
have to be sure about the time, duration of the positive ventilation. We started
It has been 15 seconds.
15 seconds now. Is it heart rate is changing?
40 still. Heart rate is 40 still.
No increase.
Okay,
No
we go
increase.
on.
We go on
Breathe
with
2, 3.
ventilation.
Breathe 2, 3.
Go on. And at least
Breathe
15
2,
seconds
3.
more.
Stop
Breathe
it there,
2,
just a
3.
sec. So I guess I'm looking at this, and I noticed that they were straight into 2-person airway support, which is a very good way of supporting airway. So I'm thinking that's actually perfectly appropriate. And I'm thinking that it was good that they checked for airway movement, and it was very clear that the team leader identified the chest wasn't moving and asked them to reposition, which was good. But what I haven't seen, and I don't know is I haven't seen any evidence of a stethoscope yet. I haven't seen any auscultation of the chest or any attempt to define a heart rate. The monitor was put on, but within the conversation, unless I missed it, they seem to have a lot of time conversing about the heart rate without defining it clearly and then taking appropriate action. So there's a conversation over a baby, which does happen in simulations, but to be honest. So I'm thinking that I would have said that this was, there's some delay in managing elements of what this baby might need. What do you think, Charles?
Sorry, John, my internet cut out for a second. I agree with you, but I can see that the dual monitoring of heart rate monitor, ECG, and the saturation probe might be taken as the heart rate, and was mentioned from the team leader, who I think does a great job in really firing up the team and giving them a real life acuity of the whole scenario.
Do you think, though, just being critical for a second, that if you've got your heart rate on a monitor and you've established your airway and you know that your heart rate is low and you've confirmed the chest is moving, that conversation should be happening, but there should also be some action at this point?
Yeah, I agree with you that we in the guidelines we say ECG may be of help in this situation. However, you cannot help but want to reassure yourself and have a listen for heart rate for one, but also, as you mentioned, for the effectiveness of your applied ventilation breath. So I would think use of a stethoscope would not be too much in this instance.
So we talk in the guidelines about confirming that the chest is moving, and then if the heart rate remains slow, then we would move to 30 seconds of ventilation followed by cardiac compressions. So at what point do cardiac compressions start? Let's let it run.
3, 2, 3. 3, 2,
Yes, sir, according to you,
3, 2, 3.
how many seconds do we have?
3, 2, 3. 40.
40.
Heart rate.
Heart rate is 40,
40.
13 seconds with ventilation, and still it is 40
40.
heart rate. So we have to be sure about the ventilation, so we have to intubate the baby.
Okay, I intubate the patient now.
Esra, would you please increase the oxygen concentration?
I can see the vocal cords.
I increase oxygen
I intubate the
concentration.
patient with an
100%.
ETT number 3.5,
I
and
check style.
the level at the corner of the mouth is about 9 centimeters
Please
here.
check the
I
level.
stabilize. Nice.
Here's my capnogram. It's attached,
After
and I can see
confirmation,
the
we will
entitled.
secure the airway.
Okay.
I can see the entitled carbon dioxide now.
Breath sounds are bilateral
I
and
will
clean.
check
Clear. This is, I
Stabilize.
think,
Breath 2, 3.
this
Breath
level
2,
is
3.
9 centimeters. Okay.
Breath 2, 3. Breath 2, 3.
We have to be
Breath
sure
to
about the
three.
ventilation now. We will
Breath
wait,
to
we will
three.
wait 30 seconds at least,
Breath 2, 3.
keeping her warm.
Breath 2, 3. Breath 2, 3. Breath 2, 3.
Is there any increase on pulse rate? Is
Breath 2,
okay?
3.
Can it?
Yeah, this
Breath
50,
Manage
a
the heart
little bit increase.
Breath 2, 3. Breath 2, 3. Breath
Heart
2,
rate is
3.
30 seconds. It
Breath
says
to
30
three.
seconds.
30 seconds left.
Breath
Okay.
to three.
We have to be sure
I'm ready
about the
for
heart
check.
rate. Heart rate is on monitor is
50.
50. Oh, still
Okay,
below the
starting.
60. Start chest
1,
compression.
2, 3.
Breath.
1, 2, 3.
Breath.
1, 2, 3.
Good day.
Breath.
Esra,
So it was 7 minutes and 6 into the scenario when cardiac compressions were started. So I guess I don't know what other people would think, but would it have been reasonable to start the compressions before the intubation and to have given some compressions, and then if things hadn't recovered, move to intubation? I thought the intubation was a nicely structured intubation. It was done with good teamwork. They had all the relevant equipment, end capnography, and so on and so forth. So that the procedure was well done, but the order and the time at which cardiac compressions were commenced seemed to me to take perhaps longer than optimal.
It's difficult in this scenario because there is no clear view of a timekeeper, no watch or anything to APGAR timer. So maybe this is due to the way the scenario is set up, John.
Possibly, but I've seen this happen in real life, and I have seen similar in simulations by other teams at other places as well. So this is not unique, but it does represent something which might be around task fixation and the airway here, rather than the global overview and the direction. And it just represents something that we see from time to time, and is not uncommon in the slightest. Could we just scroll forwards to 9 minutes and 40, please? There, stop there.
Breath to 3.
I prepare the
Breath to 3. Breath
Okay.
to 3.
It seems that on the left side there is a pneumothorax. We
Okay,
may
I-
decompress it.
okay. I prepare the pneumothorax for compress it.
Baby is okay. His heart rate is
Okay.
increasing.
Okay.
I think decompression may be relieved.
Breath to
Well, do you want to do anything else? Or think about something more?
Breath to 3.
Now,
Did we send the blood samples for electrolytes and glucose maybe?
maybe we
Breath
can
to 3.
take some samples.
So what we should say is the heart rate has come up at this point, so it's perfectly valid that they have stopped the cardiac compression. So this isn't not cardiac compressing. We'd missed the bit that I'd hoped we'd seen. It was just before that. My time index is wrong. There was just a discussion about a pneumothorax, and the point I think we probably missed the point there, but there was a conversation about it, but I think that was needling the chest, but I'm not sure. What did you think?
I didn't quite catch it when I watched it, but I appreciate that there was discussion about disparate chest sounds. But I saw there was a lot of attention to the left chest, and my question was whether this could be just a tube that may have slipped in. So I'm slightly unsure.
Okay, so we're running out of time. I think it might be useful just to let it run a bit further to where they took this debrief the mum, which is 12:30.
Okay, I see your team is just arrived. Thank you for all.
Thank you.
very much.
We have to transport your baby to Neonatal and intensive care unit. We make contact with them. Heart rate is okay for now, but he is not breathing well, so we have to support her ventilation. As soon as she gets that sensor, they will make a contact with you and your husband.
Okay, we'll stop there. So again, they're in English, which is not their main language. So whenever talking about debrief, have to put it into the context. But a little bit muffled, but actually there was quite a lot of information given to mum there. I didn't think that was a bad update in the context. It's not a natural situation, but there was an attempt to give mum the relevant information prior to moving on with the rest of the simulation.
Yes, I agree with you. It's probably very difficult to play a scenario out not in your native language. And depending on circumstances, of course, you would offer mum to come along or to be present at the baby's bedside as soon as possible. But I value that an attempt has been made to give the mum a quick update and full picture. The still that we see right now, of course, in this simulation shows on the one hand the hypothermia, which the baby now appears to have suffered. But on the other hand, it also brings to light the small self-inflating bag. And we did see how the team actually, in their very well coordinated breaths, squeezed the whole bag, and it's minimum a 250 ml bag. I would just, in a real life scenario, just to remind people that you might have a different set of bags, and you could change a bag which some people would use for preterm resuscitation to an adequately sized 500 ml bag when you encounter a bigger baby?
Any comment from others in the panel? Because I think we can probably stop this video at this point. There is a debrief. It was a good debrief. The one thing I noticed on the debrief, which was worth pointing out, is that the chairs were nicely socially distant, making sure that people were safe within the context. The actual dialogue for the debrief on this particular video is really, really difficult to hear. So it's actually not coming across at all well. So I think there's limited grounds to listen to it now. I had to listen to it 3 times to work out the dialogue, but it was a reasonably structured debrief, went through some of the key points. One thing that wasn't picked up on the debrief was the element of exposure of the baby and the hypothermia, which I thought was one of the critical elements for me in that simulation, was that the baby remained exposed throughout the whole of the resuscitation procedure on the table. And I would have said that that was a learning point for anybody who was thinking about the resuscitation in that situation.
But again, great credit to the team for having handed it in and for the many good aspects of resuscitation that we did see.
So thank you to Turkey for that video.
All right, so now we're gonna move on to the next video, just in order to watch a little bit of what's going on in the Q&A. We've had one question on non-technical skills, especially non-verbal communication, which I would like to pick up at the end of this session, after also seeing what the Austrian team did. Then we had another comment on timing of intubation, depending on various factors, and some on ventilation. And I think we can now move on and start off with the Austrian team.
Yeah, thanks, Lucas. This is from the Austrian team, and let's see how they approach this.
We were planning to pick up on the human factors at the end of both of the videos.
Okay, this scenario, Roland and I will run with you. And the case is you're called to a home delivery in the 41st week. The father called the ambulance because of a rupture of membranes, and he recognized and he mentioned green liquids and that it's smelly. So you are the first team to arrive. You two are the first team to arrive. At the same time with you, the midwife arrives. That means you have some time, and the baby is not yet delivered, so you have some time to prepare everything, and you don't have to take care for the mother. The midwife is caring for the mother. You just have to take care for the baby. The second team, the neonatal emergency team, is already called, but you will arrive a few minutes later, so I would like to ask you to wait outside, and if we call you, please come in and help your first team, help the first team. Okay? So the scenario starts now. You can go outside, and for you, the scenario starts now.
Okay, should we pause there? So, things that struck me were a completely different setup. This is very professional in terms of the environment. It's clearly looks like it's a simulation center. They have cameras mounted on the ceiling. The sound quality is superior, and they're all wearing headsets. So it's clearly been prepared in a way that is recorded, with everybody providing their own individual linked recordings. So we're going to see a different quality, I think, here from the videos, and that just reflects the professionalism of the team or the setup that they've got. For me, again, there was a good briefing of the team in terms of simulation. They were very clearly directed as to what they were meant to be doing. We've got the 4 people, but instead of being one team, he split them into 2, with a late arriving couple and the people starting it. Clear direction on the situation for the baby, clear direction on mum, and so on and so forth. So I thought a good briefing. No check of the understanding from the team back, though. Good practice would suggest you check your team understands what you've said, but in fact they went straight into off you go, now it's running. But let's see how it goes.
I agree, John. That's what I found.
emergency team. I'm Kim, this is Andrea.
Hi.
First, a few questions. Do you have any signs of COVID, like fever, coughing, sore throat, or contact to a corona-positive person? No. Okay, perfect. So the gloves and the mask are enough at the moment. So let's prepare everything.
We could use this desk.
Yeah, perfect. How much time do you think we have?
About 3 to 4 minutes.
Okay. So let's check everything. This is the checklist for term newborn resuscitation. We need a 500 milliliter bag with a face mask size 1.
Yes,
Okay.
tested, check.
Perfect. Then we need oxygen.
Here it's connected, but it's still off.
Okay, then the suction device with a catheter in case of meconium, size 16.
That's working.
Okay, then the laryngoscope.
Yeah.
Okay, and the glue tube size 50 and 60 millimeter.
Available.
Okay, perfect. So when the baby isn't breathing or floppy, then we have to suction the oropharynx first.
Okay.
Please attach the ECG as soon as possible.
Yeah.
And then start with the ventilations. And be prepared if we have to do chest compressions.
Okay. Well. You know, when the baby is not breathing, yeah, please cut the cord immediately and hand it over. We will see what condition your baby will have. We will do everything that's necessary to help your child, yeah?
Okay, so don't matter you, Charles, but there were many good things to talk about there. I don't know whether you want to take this section.
Oh, thanks, John. I guess we both agree. I enjoyed watching this previously for the professionalism, also in the scenario, as you pointed out. It's been very well put to the audience here that this is a home birth where we anticipating a slightly uncertain environment, but the team seems to do their very best to set up in a very professional way so they can best deal for the baby. I'm impressed that they have a checklist for the scenario, which they go through. I'm impressed with the equipment check, which happens, and the clear communication between the two team members. And as we also saw, the clear communication with the mother prior to the baby delivering. So those are very good things. I do note that contrary to the previous video, even though we're in a private home environment, there is no, there seems to be level 1 PPE, but one could argue that in a high incidence zone, you would want to go to level 2 PPE. We also, sorry, that's what I wanted to say with regards to the COVID situation that we're currently in. But those are all positives. I want to also pause though, and I would love to quiz the team why in this day and age they think, as explicitly said in this video, that suctioning should be performed before giving inflation breaths or airway support. And I think that's something that really is not quite as in the guidelines.
So I guess to some degree you could do that. You're given license to do that with the current guidelines. The 2015 guidelines permit you to inspect under direct vision in a floppy baby that has no respiratory effort. So if you're expecting a floppy baby that has no respiratory effort, then you might think, okay, I'm going to have a look and suck out first and then go for ventilation breaths. Although you and I are both in agreement that we would rather give the first few breaths and then if there's no response, go to suction as a maneuver after that. And that's what's written into the new versions of the guidelines, recognizing the ILCOR documents and so on. But it's very well played. I like the acting of the mother, the sounds in the background add to the ambience of a home delivery. So this is clearly very professionally done, and credit to the team for doing so. Shall we play on?
A lot of meconium. Hey, baby. Okay, thank you.
Okay. How's the tone?
No tone, completely floppy.
Okay, and breathing?
No signs of breathing.
And the color of the skin?
A cyanotic and green because of the meconium.
Okay, then I start with suctioning the oropharynx.
Yeah, there's a lot of meconium coming. Yeah, still meconium coming.
Okay.
A little bit more, and now no more meconium in the oropharynx.
Okay, I'll switch on the monitor.
Yes, and I start with 5 inflation breaths. 1, 2, 3.
Ventilation feels good.
4, 5. Okay, the baby is still not breathing, and the heart rate is below 60 beats per minute, so
Hey,
continue.
guys, please hurry up. See, it looks like we're going to have a full CPR of a newborn here. Thank you.
3, 4, 5.
Do you want a pulse oximetry?
No, not yet. It's useless. Okay, the heartbeat is 34 beats per minute, so we have to start with just compressions.
1, 2, 3.
1,
1, 2, 3.
2,
1, 2, 3.
3,
1, 2, 3.
4,
1, 2, 3.
5,
1, 2, 3.
6,
1, 2, 3.
7,
1, 2, 3.
8,
1, 2,
Team 2.
3.
9.
Hello.
2, Hi, we have the Neo team, Martina and Verena. Hi, we will check the ventilation. Stop with the compression and continue to ventilate. Okay, the chest is moving. Okay, continue with the CPR.
2, 3.
We need 100% oxygen.
2.
Martina, we need 100% oxygen.
Oxygen is 100%.
Okay, perfect.
5.
Maybe pause. Yeah.
Yeah, sorry, I wasn't sure whether my mic was on or not. So I thought there were, again, lots of good things there, but some observations to make. I like the communication between the team members. I think they work well together. It's a very structured assessment of the baby. What do you think about immediate cord clamping there? That presupposes that they knew the baby was going to be unwell, for me, because it was an instruction given before the baby came out to cut the cord immediately. So I was thinking maybe that's just a function of the story that they already know about the baby or something like that. But would it be reasonable to have said, okay, let's assess the baby, and then if we're unhappy, cut the cord? What do you think?
John, I couldn't agree more. It's particularly in this particular setting of home birth, where you got limited intrapartum monitoring. You know, why it's very reasonable to see what the product of this difficult delivery was. So you know, my personal practice would be to have a look at the baby before I decide on clamping the cord straight away. And you know, I don't think there's much lost in doing that.
No.
So yeah, point to you.
So I'm mindful of time. So there was an assessment. There's drying and wrapping of the baby. It's floppy. It's not breathing. There is no auscultation again, interestingly, and they've gone straight for ECG leads. And I'm thinking, certainly as far as our practice would be concerned, and maybe those of our community midwives, they wouldn't have an ECG. They would be listening with a stethoscope and checking the heart rate.
But this is the neonatal resource team, and they came with a full monitor. So credit to them and to Austria for providing all of this. But you're right, not everybody has this.
Yeah. So that, you know, and again, nice 5 inflation breaths given with check of whether the chest is moving. So I thought that was nicely done. And interesting though, again, the baby is left very exposed. So we've left with a naked baby on a towel. And I'm just trying to recall whether the wet towel was removed or not, but this is a baby lying exposed in a home environment with no overhead heater, potentially getting cold.
Yeah, we saw with the suctioning of the oropharynx how long it actually takes to clear the oropharynx from meconium. And I think this video, in this sense, very nicely illustrates how much time to first breath is actually lost. So I think our new, the currently under public comment guidelines, we'll see some nice comments on that, and I'm looking forward to discussing this with the community. I wanted to point out the parental update. Parents look adequately worried, and the team adequately feels they need to do chest compression. But sadly, the mother and father are not given an update on the baby at all. The team is very task focused, is very team focused, but part of the team is the parents, and they are kept in the dark.
But there's only 2 of them till the other guys turn up, who then take over. So should we let it run a couple more minutes and then maybe we break into discussion?
Now prepare everything for an IO. Red needle, please.
2, 3.
Okay, I will prepare the IO.
3,
9,
2, 3.
This is a life-threatening event for your child. We will do everything what we can.
3.
Yes,
12,
please.
2, 3.
13,
Okay.
2, 3.
14,
2, 3.
Take this
15. Okay, let's
Okay,
stop.
we check.
Okay, we have to continue with the CPR.
1, 2, 3.
Okay.
1,
Oh, something to
2,
test.
3.
Disinfection, please.
2, 3.
3.
Stop it there,
3.
please. So just to move it. So I thought that was a really interesting section. And again, number of good things. There was a recognition that this is a baby that needed vascular access and a move too, but I thought it was interesting that the selection was of an intraosseous needle in the first instance, which I guess for us hospital-based guys would probably not be the thing that we would do in the first instance. We would aim for a UVC, which in fact is what the Turkish team did. So is that a function of the fact this is a home delivery, do you think?
I thought so, John. I'm a friend of an IO when you need one, but at the same time, this is a highly professional, well-trained team. You would think that if they wanted, they could get the UVC in. However, they won't have access to X-rays, etc., to confirm the absolute central position. Whether that's necessary or not is another matter.
So I've heard it said that you can get an IO in needle faster than you can put a UVC in, because you don't have to get all the equipment spread out. You just get your drill, and then it's in. So I guess there's a debate to be had there in the community setting. Things I liked, even if they were slightly abrupt, is there was an update to mum at this point. And that what I particularly liked, although it's quite possibly upsetting, is the words life-threatening. So whoever came in used the words, this is a life-threatening situation, thereby framing it very accurately and putting it in unambiguous terms that we are in a difficult situation here, and then they move on to the venous access. I'm thinking for the purposes of discussion, the rest of the stimulation is done very professionally. Access is obtained, adrenaline is given in the right doses in the right manner, and an output is regained. And then they move to debrief. But I was thinking for the purposes of our session, perhaps with 10 or 11 minutes to go, there might be a merit in stopping the videos at this point and just opening up the discussion. I've got no idea what's been happening in terms of streamed questions or anything like that.
Thank you, John. I think it's a perfectly reasonable time to look across and see what's been coming in. I think Lucas has at least a couple of questions, and I indeed have at least one.
Yeah, so the very first question that was also raised by the audience, and I think that's not only focused on neonatal, but on a general situation, is how to deal with non-technical skills in times of COVID-19, especially non-verbal communication. I think that question was raised. Now, before I would like to ask John and Charles, what I want to state here is that we had an exceptionally nice example by Jens' team when they were working on the checklists, because checklisting is not, I think, as easy as it states or as trivial, because you always need to have a standardized answer to each point. And we've heard that because when they were asking for the bag, the answer was checked. When they asked for the tube, the answer was available. So we see this is highly professional. And I think before we go into nonverbal communication, there are a lot of other tools that need to be established, like, for example, closed loop, etc. Now, John and Charles, what do you think about the nonverbal communication and NTS that we've seen here from both teams, and also taking into account COVID-19?
I take this first, John, if I may. Well, the nonverbal communication with both teams was, I very much appreciate this. It's difficult to perform on camera, and to perform on camera knowing that you're going to submit this to an international conference. So great credit to both teams for having done this. Clearly, the amount of PPE in the Turkish scenario adds another layer to the non-verbal communication. And I think that we had much more talk and chatter amongst the Turkish team, which may be reflective of that. If you don't see faces, if you can't make sense of what people's non-verbal grimacing, etc. is, then you do maybe need to talk more. That's great. In the second example, resuscitating a baby by the bedside of the mother is always a challenge, and ideally you want the parents to give a good view. You don't want to obstruct it with your body, but the way it was set up, at least one of the resuscitators had a back to the parents, and therefore made it difficult for the parents to see what's happening, and for the resuscitators to give any feedback to the parent. But it's not a criticism. It's a fact. John, what do you think?
I guess comparing and contrasting the manner of the interaction between the team members in the Austrian video was, I would say, well rehearsed. I don't mean that in terms of they practiced it beforehand, but they were clearly used to communicating in that manner, and it was something which they've been drilled in. And I think that's an important issue, is practice. And that's where simulation comes in, because it gives you the opportunity to practice that, so that when you do it for real life, you're better at it. The point about the checklists, I think, is a valid one. There's another very good example on that video for those who watch it completely, and that's at 11 minutes and 30, where they intubate the patient. And there's another very good example of using a checklist to make sure that all the relevant stuff is there for the intubation, and then running through the intubation and the procedure as they do it as a checklist, with a two-way communication and some closed loop to boot. So for that team, checklists are clearly an integral part of how they work, whereas for the Turkish team, they didn't have checklists, and there were certain elements of the procedures during that video which might have been improved, although again, without a checklist, it was still a well done intubation, and with appropriate steps and rehearse. So you don't necessarily need a tick chart, although some people might feel that a tick chart helps maintain the structure. I don't know, Lucas, this is more your field, isn't it? The checklists and feedback.
Well, I think that was just one point here, but yeah, I think if we consider NTS, I would really appreciate it if we would integrate some very fundamental works of it, like really directed commands, closed loop, etc. And I think if that all works, then nonverbal communication is another aspect that also comes in here. But there are so many basic features also that we have seen from all teams that are really excellent, and we need to translate that also in the clinical practice. So that is my opinion here, basically. All right, then maybe another thing that came up during the review by John and Charles and was also raised here by the audience in terms of intubation, but we've also discussed the vascular access. I would just like to get back to that discussion about the intraosseous versus the UVC here, because those were pre-hospital scenarios, so in the EMS. So is it time here to consider like expertise environment equipment, or what are your thoughts on that, also taking into account the new guidelines here released for public review? So I'm really curious on the answers here.
Okay, so if I start this one off, Charles, and then you can chip in. So in a hospital setting, the default would be to go for a UVC because it's easy, usually easy, relatively safe, and you get central venous access, which is reliable and can be used for a number of things, including blood gases and sugars, as well as for giving drugs and so on and so forth. And it doesn't have to be sterile, it needs to be clean in the emergency setting, so you don't need to have a complete sterile field. You just acknowledge that this is an emergency procedure. And with the kit there, it takes very little time indeed, literally seconds. Intraosseous for EMS technicians, for those in an emergency department where IO is often used in the pediatric and adult fields, they may be more familiar with that than sticking in pieces of plastic into an umbilicus. So they might reach for the IO because it is something they're familiar with. Admittedly, an infant is smaller, but a mature term infant is approaching a small infant. A preterm is a completely different situation where I would question the validity of IO because there's no marrow space to actually get it into. So I can understand the use of IO in the EMS setting, but I would equally say if you had the equipment that umbilical venous access was equally valid. But for an EMS technician, I suspect that's not a familiar territory.
I agree with everything that John said. The general comment I would have is, in this home birth situation where we may not be quite sure about the extent of antenatal fetal compromise and the condition of the baby during labor, it may well have been that effective airway management and one round of CPR would have done the baby enough justice to transition. So whilst going in with an IO is a rapid way of finding access, the need for it needs to be carefully assessed, because of once you have it in, you need to make sure it stays in. And whilst you're in a non-familiar, non-emergency room setting, it may be also an added challenge to keep the IO from falling out. It also accounts for the UVC. Its fixation is always the issue.
Okay, thank you, John and Charles. I think that was quite an interesting discussion on this issue. Then before closing, we have just one question that was raised previously about the ventilation rate of the Turkish team, counting 1, 2, 3. The question was if that rate was too fast or not. So what do you think of that, to answer it straightforward?
Okay, so I mean, if you look at both of those, you will find variances from the guidelines and from the sequencing that is suggested in the manuals, and NLS manual particularly. We haven't picked up on all of these things because to do so would be to be very deconstructive, and there are many other areas of discussion. The rate at which we ventilate varies between the European guidelines and the American guidelines. Helping Babies Breathe recommend 40 breaths a minute. We talk about 30. The Americans are slightly faster, I believe. The evidence suggests that a rate of 30 is the rate at which you may achieve the biggest CO2 clearance in the first instance. So we've stuck with 30 for our guidelines. That doesn't mean that other rates of ventilation are wrong. It's just there are differences, and I think it reflects something, which is a lot of what we do is opinion-based, not evidence-based. So it's, you know, just because we do it one way doesn't make another way wrong. it makes it different. And that's the whole point about ILCOR and the evidence bit, is to try and improve the evidence so that what we actually do is better and evidence-based. I think for newborns, we're very mindful of the fact that a lot of what we do lacks to some degree in evidence base. So I wouldn't criticize somebody for ventilating at a different rate to the one that was in our manual, because providing it was doing the job, then you're achieving what you're meant to achieve, if that makes sense.
I think, and it's also credit to both teams that they had a structured way of counting. The Turkish team counted down, the Austrian team counted up. And what I really liked about the Austrian team was they said they counted out the cycles of CPR, which after 15, then they changed over. So that was good teamwork, good practice.
Okay, great. Thank you to both of you for this concise answer. I think for the sake of time, we're gonna move on and conclude this session. And I would hand over to Robin to do so.
Thank you, Lucas. So all that remains for me to do is to say thank you very much indeed, both to John and to Charles for your expertise and your commentary, to thank Lucas for his support as co-chair, and most importantly, to thank those teams that submitted 2 excellent yet very different videos, without which, of course, this wouldn't be possible. It takes a lot of courage and a lot of work to produce something like that. And then lastly, thank you to all of our delegates that participated in the Q&A and interacted with us all. So thank you very much all, very much indeed. And hopefully we'll see you at the next session on Saturday if you're interested in adult resuscitation. Do remember that all of the videos submitted are available on the platform, both for pediatrics, for NLS and for adults for viewing at any time, so you can make your own call on the quality of what they've done for you. So thank you all very much indeed. Take care, one and all.